I think we want to segue to our second segment, and we'll talk about payer coverage for continuous glucose monitoring. So shift gears a little bit here. Maybe we'll start with the clinical rationale for CGM, as opposed to kind of the old-fashioned way. And Bob, there was a study published in the American Journal of Managed Care in 2011 that really looked at some of the outcomes related to this.
Yeah, so what that study did was, for the first time, really quantitate the cost associated with hypoglycemia and a hypoglycemic admission to the hospital. And the realization, what now subsequent data has demonstrated, is there are more people admitted to the hospital for hypoglycemia than hyperglycemia. And that's really a big shift from what traditionally had been the case, or what most people think about. And so that then makes one think, what can you do to prevent hypoglycemia? And one tool is certainly continuous glucose monitoring that could alarm a patient when their blood sugar is getting dangerously low. They take an action and they don't end up losing consciousness, ending up in the hospital, and therefore can save significant costs and morbidity.
Just adding on to that, it doesn't even have to be a full admission. Even what we would consider a simple ER visit related to hypoglycemia, with an ambulance transfer and a stay in the ER and the evaluation that occurs in the ER, can run up quite a bill very quickly for a stay that has the potential to have been prevented.
Mm-hmm. So has this made its way into the guidelines yet? I mean, there's still a little bit of controversy around sort of when this should be used. What do the guidelines say?
So there's clearly evidence that exists about when CGM is successful and where it has proven to be of benefit, and particularly in type 1 patients who are willing to use the technology, and that it shows benefit both in terms of improving glycemic control and lowering risk of hypoglycemia. Once you get outside of that, causation data becomes very thin. So you see observational data where there's clearly a relationship between hypoglycemia and, as Bob said, if you can give them the message and that prevents the hypoglycemic event, well, then that is optimal. But the question that comes up is there's not a lot of data that says if we take folks who we're not biased and selected for, and we give them a CGM, will they use that information and change their behavior such that it actually it relates and yields a decrease in hypoglycemia? We would all like to think so, and we would all like to hope so, and it sure sounds logical. But whether it's actually true or not is what we're waiting to see, and that is one of the key factors in driving coverage.
And I think that kind of data is starting to accumulate. I think you're right. The important is not just giving this device to somebody, but educating them on how to use it and how to use the information. And that's where it needs to be done right to demonstrate value. If it's done wrong, you might not see an advantage.
See, and I'm so glad you said that, Dr. Gabbay, because that's where diabetes educators have the role.
Sure.
Where when the physician interprets the data, and there occurs a CPT code for billing that and getting money, then that data comes to us to embed lifestyle changes to control those patterns of hyper and hypoglycemia. But in terms of what Dr. Snow said too, that type 1s generally benefit the most because of the blood glucose variability and the peaks and valleys. But CMS Medicare does cover CGM now, professional CGM and personal CGM for also the type 2 population who are insulin dependent. And it's an adjunct. CGM is actually an adjunct to self-monitoring of blood glucose. And there's strict criteria with CMS for coverage, where they have to be testing 4 or 5 times a day, be on insulin. But it's good news that Medicare is starting to cover professional and personal use.
It's fantastic news. We have at Johnson, we have a large type 1 population. And for them, they reach Medicare age, and now they have to go off of their continuous glucose monitor, which is a big problem. But I think you'll see in the not too distant future this spreading to more use in type 2, based on the kind of evidence of people that are on multi-dose insulin can clearly benefit.
Right. And so there have been some studies that have helped in this regard, I believe. The Diamond study being one of those. Could you talk a little bit about that?
Sure. So the Diamond study has been a series of studies, and some of the results have come out. And so
one of the studies just recently looked at just comparing using a continuous glucose monitor to typical home glucose monitoring, and which would be better in a type 1 population on insulin. There were two studies. One Diamond had a 1-point drop in A1C. A Swedish study had a 0.5 drop in A1C, designed a little bit differently, but clearly there was benefit. And that's also helped to allow CMS and presumably others to say this doesn't have to be an adjunct to home glucose monitoring. It can largely replace it.
Mm-hmm. Great. How about the importance of the FDA expanded indication or Medicare coverage decision with Dexcom 5?
Well, clearly, from a payer perspective, it is always reassuring when what is being requested to be covered is actually approved by the FDA for that use. We see a lot of requests for off-label use for all sorts of things, some very reasonable and legitimate, others not so. But once you have that FDA stamp of approval, there's a significant advantage, not the least of which is it usually means that there's legitimate scientific evidence that fell behind that decision on the FDA's part, and that scientific evidence is what supports the use.
Mm-hmm.